Hi and welcome to the E-Module training for primary care medical officers in Selangor. This module is created to guide you in managing of asthma in adults at primary care level. The outline of this module includes what is asthma, making diagnosis of asthma, investigation and management of asthma, indications for referral, treatment in special populations. What is asthma? Asthma is a heterogeneous disease characterized by chronic airway inflammation. It has history of respiratory symptoms such as wheeze, shortness of breath, chest tightness, and cough that vary over time and in intensity together with variable expiratory airflow limitation. Due to persistent airway inflammation, later it becomes fixed airway obstruction. Asthma affecting 1 to 29% of the population around the world. It is estimated nearly 300 million individuals are asthmatic globally. National Health and Morbidity Survey 2011 shows that 6.4% of Malaysians has asthma.
One of the major risk factors of asthma is genetic. Besides genetic, environmental factors like smoking, air pollution, pain, pesticides also are the risk factor for asthma. Other risk factors are like overweight, obesity, gastroesophageal reflux, rhinorrhea, and allergic rhinitis.
Making diagnosis of asthma has two main key features. One, a history of respiratory symptoms such as wheeze, shortness of breath, and chest tightness, cough that vary over time and intensity, and variable expiratory airflow limitation. Diagnostic criteria for asthma. 1. A history of variable respiratory symptoms. Typically, symptoms are wheeze, shortness of breath, chest tightness, cough, which generally have more than one of these symptoms, occur variably over time and vary in intensity, occur or worse at night or on waking, triggered by exercise, laughter, allergens or cold air, occur with or worsen with viral infection. Secondly, confirm variable expiratory airflow limitations. When FEV1 is low, document that FEV1C over FVC ratio is below the lower limit of normal, and variation in expiratory lung function, one or more of the following: increase in FEV1 of more than 12% and more than 200 ml shows a positive bronchodilator responsiveness reversibility test. Average daily diurnal PEF variability is more than 10%. FEV1 increases more than 12% and more than 200 ml from baseline after 4 weeks of anti-inflammatory treatment outside respiratory infections. Apart from diagnostic criteria, as I mentioned earlier, history of allergic rhinitis, eczema, and a family history of asthma or allergy are salient histories in making diagnosis of asthma. Asthma patients usually present asymptomatically to us. In general physical examination, some may have eczema. Use of accessory muscle, hyperventilation, audible wheeze, and rhonchi on auscultation are seen in acute or severe asthma patients. Now, let us see the investigations for asthma. The table shows different investigations that can be performed for diagnosing asthma. To demonstrate airway obstruction, spirometry will be the ideal test. Bronchodilator reversibility test and peak flow charting to demonstrate of airway obstruction variability. While to detect the eosinophilic inflammation or atopy, blood eosinophil count, IgE level and FeNO test will be used. Spirometry is the recommended test to confirm asthma. It is useful in demonstration of airway obstruction variability. This test should be carried out by trained personnel using well-maintained and calibrated equipment. The other investigation is peak expiratory flow measurement. Peak flow monitored over 1 to 2 weeks. The mean variability is calculated. Daily diurnal PEF variability is calculated from twice daily PEF and average over 1 week. Variability more than 20% indicates a positive test. Remember, diagnosis of asthma is based typically on clinical history and supported by positive obstructive airflow reversibility with spirometry. The higher the reversibility, the higher the probability of asthma. The following features decrease the probability that symptoms are due to asthma: isolated cough, chronic sputum production, chest pain, absence of wheeze during dyspneic, symptoms beginning later in life, and chronic smoker. How do we assess an asthma patient? For every patient, asthma control is assessed in two domains: symptom control and risk of adverse outcomes. Assess the symptom control over the last 4 weeks. Identify any other risk factor, for example, high reliever usage, smoking exposure, or socioeconomic problems. Assess for comorbidities such as rhinitis, gastroesophageal reflux disease, and obesity that could contribute to symptom burden and poor quality of life. Assess treatment issues, particularly inhaler technique and adherence. This is GINA assessment tool of asthma control in adults. To assess symptom control, ask about the following in the past 4 weeks: frequency of asthma symptoms, any night waking due to asthma or limitations of activity, and for patient using a SABA reliever, frequency of its use for relief of symptoms. Based on the answer, level of asthma control will be categorized whether it is well controlled, partially controlled, or uncontrolled. Some clinic uses asthma control test (ACT). The ACT has 4 symptoms questions plus patient self-assessed control. Scores of 20 to 25 are classified as well controlled, 16 to 19 as not well controlled, and 5 to 15 as very poorly controlled asthma. Management of asthma. The long-term goals of asthma management are to achieve good control of symptoms and maintain normal activity levels, to minimize the risk of asthma-related death, exacerbations, persistent airflow limitation, and side effects. Patients should be encouraged to participate in decision of their treatment and given the opportunity to express their expectations and concern. Good communication by healthcare providers are essential as the basis for good outcome. Low health literacy is associated with reduced knowledge and worse asthma control. The pharmacological treatment of asthma fall into the following main categories: controller, reliever medication, and add-on therapies. Controller medication using an anti-inflammatory reliever, low-dose ICS formoterol. In step 3 to 5, the patient takes maintenance controller treatment, daily or twice daily ICS formoterol. This is called maintenance and reliever therapy, MAT. Reliever medications provide to all patients for as needed relief of breakthrough symptoms, including during worsening symptoms of asthma or exacerbation. Reliever includes the anti-inflammatory relievers ICS formoterol and ICS SABA and SABA alone. GINA does not recommend treatment of asthma in adults with SABA alone. Evidence shows SABA-only treatment does not protect patients from severe exacerbation, and that regular use of SABA increases the risk of exacerbation. Therefore, GINA recommends all asthma patients should receive ICS-containing controller treatment. ICS-containing treatment should be initiated as soon as possible after the diagnosis for asthma because even mild asthma can have severe exacerbation. Preventing severe exacerbation, reducing symptoms, and improves patients' lung function, and it also reduces asthma, hospitalization, and death. Before starting initial controller treatment, record evidence for the diagnosis of asthma, record the patient's level of symptom control and risk factors including lung function, Consider factors influencing choice between available treatment options, including likely adherence with daily ICH-containing treatment, particularly if the reliever is SABA, and also schedule a follow-up visit. Based on GINA 2023, asthma treatment for adults divided into two tracks, track 1 and track 2. Track 1, the preferred approach by GINA, where the reliever is as needed low-dose ICS formoterol, while the alternative approach, track 2, the reliever is as needed SABA or as needed ICS SABA. Track 1. This is the preferred approach recommended by GINA for adults because of the extensive evidence that using low-dose ICS formoterol reduces the risk of severe exacerbation compared with using SABA as reliever with similar symptom control. In addition, the treatment regime is simpler with patient using a single medication for reliever and for maintenance treatment if prescribed across treatment steps. With this approach, when a patient at any treatment step has asthma symptom, they use low-dose ICS formoterol in a single inhaler for symptom relief and to provide anti-inflammatory therapy. In steps 3 to 5, patients also take ICS formoterol as their daily maintenance treatment together. This is called maintenance and reliever therapy, MAT. Track 2. This is an alternative approach if track 1 is not possible, or if a patient's asthma is stable with good adherence and no exacerbation on their current therapy. However, before prescribing a regimen with SABA alone reliever, consider if the patient is likely to be adherent with their maintenance therapy, as otherwise they will be in a higher risk of exacerbations. In step 1, the patient takes a SABA and a low dose of ICS together for symptom relief when symptoms occur. In step 2 to 5, a SABA or combination of ICS SABA is used for symptom relief, and the patient takes maintenance ICS containing medication regularly every day. If the reliever and maintenance medication are in different devices, make sure that the patient can use each inhaler correctly. This diagram showed recommended initial asthma treatment for adults based on their symptoms. And there is two tracks given, the preferred initial treatment, track 1, and alternative initial treatment, track 2. How often should asthma patient be reviewed? The frequency of visit depends upon patient's initial level of control, response to treatment, level of engagement in self-management. Ideally, patients should be seen 1 to 3 months after starting treatment and every 3 to 12 months thereafter. After an exacerbation, a review visit within a week should be scheduled.
Now, how do we step up asthma treatment? As all of us know, asthma is a variable condition. An adjustment of controller treatment by the clinician and or the patient may be needed. It can be categorized into 3 categories: short-term step-up, day-to-day adjustment, and the third one is sustained step-up. Sustained step-up for at least 2 to 3 months. If symptoms and or exacerbation persist despite 2 to 3 months of controller treatment, assess the following common issue before considering a step-up: incorrect inhaler technique, poor adherence, modifiable risk factor like smoking, are symptoms due to comorbid condition such as allergic rhinitis.
Once good asthma control has been achieved and maintained for 2 to 3 months, treatment can often be successfully reduced. Consider stepping down when asthma symptoms have been well controlled and lung function has been stable for 3 or more months. Choose an appropriate timing for stepping down asthma treatment. For example, when there is no respiratory infection, patient not traveling, and not pregnant. Engage the patient in the process. During stepping down, document their asthma status, provide clear instruction, provide a written asthma action plan, and ensure the patient has sufficient medication to resume their previous dose if necessary. Monitor symptoms and schedule a follow-up visit. Stepping down ICS doses by 25 to 50% at 3-month intervals is feasible and safe for most of the patients. Remember, we should never completely stop ICS in adults with asthma unless this is needed temporarily to confirm the diagnosis for asthma. LAMA or LABA should be never used as monotherapy in asthma patients. LABA monotherapy can increase the risk of severe exacerbation in patients receiving LAMA without any ICS. This table shows low, medium, and high dose of ICS. Low dose ICS provides most of the clinical benefit for asthma patients. However, some patients may need medium dose ICS if their asthma is uncontrolled or they have ongoing exacerbation despite good adherence and correct technique with a low dose ICS. High dose ICS is needed by very few patients, and its long-term use is associated with an increased risk of local and systemic side effects, which must be balanced against the potential benefits. Using an inhaler is a skill that must be learned and maintained in order for the medication to be delivered effectively. Poor inhaler technique leads to poor asthma control, increased risk of exacerbation, and increased adverse effects. There are a few strategies to ensure effective use of inhaler. First, check inhaler technique at every opportunity. Ask the patient to show you how they use the inhaler. Show the patient how to use the device correctly with a physical demonstration. Check technique again, paying attention to problematic steps. You may need to repeat this process 2 to 3 times within the same session for the patient to master the correct technique. Confirm that you have checklists for each of the inhalers you prescribe and can demonstrate correct technique on them. Pharmacists and nurses can provide highly effective inhaler techniques. These are some examples of inhalers that are available in our primary care settings, which are commonly used in asthma patients. Fluticasone propionate, ICS, salbutamol, SABA.
The following medication also available in our clinic kesihatan. We do have budesonide formoterol ICS plus LABA, beclametasone formoterol ICS plus LABA, and salmeterol fluticasone ICS plus LABA.
With a chronic disease such as asthma, it is important for patients to be provided with education and skill in order to effectively manage their asthma. The three essential components for asthma self-management are self-monitoring of symptoms and or PEF, written asthma action plan, regular medical review by healthcare providers. First, self-monitoring of symptoms or PEF. Patients should be trained to keep track of their symptoms with or without a diary and notice and take action if necessary when symptoms start to worsen. In this diary, patient can mark the days when their asthma symptoms worsen and what was the triggering factors. The picture shows samples of diary that are available in our clinic. Secondly, written asthma action plan. It helps patients how to make short-term changes to their treatment in response to changes in their symptoms and PEF. They also describe how and when to assess medical care. The term written action plan includes printed, digital or pictorial plans. For example, the patient is given a record of the instructions. Asthma action plan includes a traffic light for the asthma zone. The green zone is when you are doing well and your asthma is in control. Patient takes their normal medications and their peak flow is around their best reading. The yellow zone is when your asthma is getting worse. Require reliever inhaler more than usual and not lasting for hours. If no improvement, and they can take prescribed prednisolone tablets. If symptoms worsening, they can visit the nearest clinic. The red zone is a medical alert. They may be very short of breath, or their reliever medication have not helped, or they cannot do their usual activities, or their symptoms are same or get worse after 24 hours in yellow zone. It is important to call 999 and get immediate medical help. While waiting for the ambulance and using their spacer, take one puff at a time of reliever, breathing at a normal rate for 4 to 5 breaths every 30 seconds. Using spacer, they can take up to 10 puffs in 10 minutes. Repeat this till the ambulance arrives. The third component of effective asthma self-management education is regular review by a healthcare provider or trained healthcare worker. Follow-up consultations should take place at regular intervals. Regular review should include the following. Ask the patient if they have any questions and concerns. Assess asthma control. Assess treatment issues. Following up asthma patient. Patient's scheduled visits are suggested as follows: 1 to 3 months after starting treatment, and every 3 to 6 months once the patient stable. In addition to pharmacological treatments, non-pharmacological strategy may be considered to assist in improving symptom control and/or reducing future risk of asthma. At every visit, strongly encourage people with asthma who smokes to quit smoking. Regular physical activities improve cardiopulmonary fitness and can have a small benefit for asthma control and lung function. In management of occupational asthma, identify and eliminate occupational sensitizers as soon as possible. Always ask about asthma before prescribing NSAIDs and advise patients to stop using them if asthma worsens. Encourage patients with asthma to consume a diet high in fruit and vegetables for its general health benefits. For obese adults with asthma, a weight reduction program plus twice weekly aerobic and strength exercises is more effective for symptom control than weight reduction alone. Breathing exercise may be useful supplement to asthma, pharmacotherapy for symptoms and quality of life. Encourage people with asthma to use non-polluting heating and cooking sources. Vaccination, influenza and pneumococcal recommended in asthma patients. Moderate to severe asthma recommended for annual influenza vaccination. Briefly on asthma COPD overlap syndrome, which is also known as ACOS. ACOS are terms used to collectively describe patients who have persistent airflow limitation, together with clinical features that are consistent with both asthma and COPD. Start treatment as for asthma until further investigations has been performed. Patients with features or diagnosis of both asthma and COPD will usually also require an add-on treatment with LABA and/or LAMA to provide adequate symptom control. Following are the indications for referral to hospital when you have difficulty in confirming the diagnosis of asthma, suspected occupational asthma, poor response to asthma, any risk factors for asthma-related death, asthma in pregnancy, where in this case we can refer this patient to our family medicine specialist in our clinic, asthma with multiple comorbidities, symptoms suggesting complication or subtypes of asthma. Treatment in specific populations or contexts. Most patients with asthma, either allergic or non-allergic, have concurrent rhinitis, and 10 to 40% of patients with allergic rhinitis have asthma. It is recommended to use intranasal corticosteroids in these patients. Exercise-induced bronchoconstriction, EIB, where patient will have shortness of breath or wheezing during exercise. The recommended treatment is ICS formoterol or ICS with SABA as needed, can be used for relief of symptoms and before exercise. In elderly patients, they may have difficulties with complex medication regimes, and prescribing of multiple inhaler devices should be avoided if possible. In case of gastroesophageal reflux disease, symptomatic reflux should be treated with anti-reflux therapy, but there is no benefit from treating asymptomatic reflux in asthma. Anxiety and depression associated with worse symptoms and quality of life. Drug treatments and cognitive behavior therapy have been useful in asthma patients. Aspirin exacerbated respiratory disease AERD occurs following ingestion of aspirin or NSAIDs, where an acute asthma attack develops within minutes to 1 to 2 hours. ICS are the mainstay of asthma therapy in AERD, but oral corticosteroids are also sometimes required. Desensitization to to aspirin may be helpful in this case. Food allergy and anaphylaxis. Confirmed food allergy is a risk factor for asthma-related death. Should also have an anaphylaxis plan and be trained in appropriate avoidance strategies and use of injectable epinephrine. In case of surgery, whenever possible, good asthma control should be achieved pre-operatively. Asthma control often changes during pregnancy. In approximately one-third of women, asthma symptoms worsen. In one-third, they improve, and in the remaining one-third, they remain unchanged. The approach is the same as to any non-pregnant asthma patient. All patients are receiving ICS-containing therapy. Exacerbations and poor symptom control are associated with worse outcome for both the baby, and they may have preterm delivery, low birth weight, increased perinatal mortality, and the mother may develop preeclampsia. The following should be emphasized in a pregnant lady: education on good asthma control, frequent monitoring 4 to 6 weeks, stepping down medication should be done after delivery if asthma is well controlled. Asthma medications can be used normally during breastfeeding. Malaysian CPG Management of Asthma in Adults, published in 2017, and GINA Guideline, edition 2023, are the references used in this presentation. May this module will be helpful in managing of asthma at primary care level. See you in part 2. Thank you.